Hello, and welcome to today's training on Behavioral Support Services, also known as BSS. This training prepares staff to understand the history behind disability services, the evolution of behavioral supports, and the current standards for BSS within the Home and Community-Based Services waiver system. We will cover how the waiver works, the role of the individualized support team, the philosophy of modern behavioral support, and the compliance requirements that protect individuals and providers. Accuracy in this training is imperative. These expectations guide ethical service delivery, determine compliance, and impact the lives and rights of the individuals we support. History of disability services. To understand behavioral support services today, we need to understand where disability services have been. Institutionalization era. It began in the 1700s, where individuals with intellectual and developmental disabilities, IDD, and mental health conditions were often segregated in state hospitals. By 1955, half of all hospital beds in the U.S. were psychiatric beds, with many inhumane practices. Deinstitutionalization movement, rights movements, and public awareness of poor conditions in institutions led to the landmark Olmstead v. LC, 1999, Supreme Court ruling, which declared institutionalizing people with disabilities as unlawful discrimination. Community-based care. Home and community-based services, HCBS programs, emerged as alternatives to institutionalization, focusing on inclusion, independence, and dignity. Evolution of behavioral support. Behavioral support has also evolved significantly. Early approaches focused on behavior modification using stimulus response and reinforcement punishment methods, for example, Pavlov and B.F. Skinner. Next, positive behavioral supports, PBS. It is developed as a person-centered approach, viewing behavior as communication and emphasizing proactive strategies, strengths-based interventions, and the science of happiness. Modern philosophy. It incorporates trauma-informed care and the biopsychosocial approach, focusing on the individual's physical, emotional, and social needs. Core principles of behavioral support services, BSS. Behavioral support services follow these core principles. First, person-centered approach. It focuses on individual strengths, goals, and independence. Next, proactive strategies, which prevent challenging behaviors by addressing triggers and teaching new skills. Reactive strategies. Manage behavior safely and respectfully, focusing on de-escalation and dignity. Another core principle is collaboration. Work with the Individualized Support Team, IST, to ensure consistent and effective support. Lastly, respect for rights. Avoid restrictive interventions unless absolutely necessary, and uphold the dignity of risk. Purpose of BSS. Behavioral support services aim to help individuals with IDD and mental health conditions learn positive behaviors, reduce interfering behaviors, and achieve meaningful, self-directed lives with minimal dependence on paid supports. The language we use. Language shapes culture. It also shapes power. First, person-centered language. Use respectful, empowering, and clear language that emphasizes strengths, dignity, and self-determination. Avoid defining individuals by their disabilities. Next, avoid system speak. Replace clinical or outdated terms with plain, relatable alternatives. For example, instead of elopement, use unplanned departure. Instead of non-compliant, use chooses not to participate. Next, respect preferences. Some individuals may prefer identity-first language, for example, autistic person, as a positive cultural identifier. Always ask for their preference. Lastly, promote understanding. Use language that fosters collaboration and avoids power struggles or stereotypes. Here are the required language replacements. Instead of elopement or AWOL, say leaves or unplanned departure. This keeps the focus on safety without criminalizing the person. Instead of inappropriate or maladaptive, say interfering. Inappropriate is subjective. Interfering is clearer and more objective. Instead of consumer, patient, client, or participant, say individual. People are people first. Instead of efficacy, say effectiveness. It's clearer and easier for everyone to understand. Instead of stimulus or antecedent, say trigger or cue. Again, plain language improves team consistency. Instead of non-compliant, say chooses not to participate. That phrase respects rights and avoids turning support into a power struggle. Instead of resistant, say hesitant or reluctant. This invites curiosity, why, rather than blame. Instead of defiant or oppositional, say prefers another option. This aligns with choice and autonomy. Instead of consequence, say result or outcome. Consequence can imply punishment. Outcome is neutral. Instead of SIB, say self-harm. It's clearer for broader teams and better for safety communication. We use these alternatives because people are people first. Labels can reduce someone to a behavior or diagnosis. Plain language helps everyone understand, including families, DSPs, and community partners. System speak creates power struggles, especially words like non-compliant or defiant. We avoid subjectivity. What is inappropriate to one staff member may not be inappropriate to another. In BSS, clarity protects rights and improves consistency. How the waiver works. The Home and Community-Based Services HCBS waiver program allows Medicaid funds to be used for community-based services instead of institutional care. Its primary goal is to promote independence and interdependence, helping individuals with disabilities live meaningful, self-directed lives in their own homes and communities. Key points. Payer of last resort. Waiver services are supplemental and should only be used if natural supports, such as family, friends, and community resources, cannot meet the individual's needs. Person-centered planning. The waiver uses the Life Course Framework, TM, to help individuals articulate their goals and develop a person-centered individualized support plan. PCISP, Behavioral Support Services, BSS. If interfering behaviors hinder an individual's ability to achieve their goals, BSS may be included in the PCISP to provide necessary support. Individualized Support Team. The IST is a collaborative team chosen by the individual or their legal representative to support them in achieving their good life. The individual and their legal guardian, if applicable, is the leader of the team, and all decisions should prioritize their goals, autonomy, and dignity of risk. The IST includes paid professionals, family, friends, and community members, each contributing based on their unique roles. Primary diagnosis and related challenges. Individuals qualify for HCBS waivers based on their primary diagnosis of an intellectual or developmental disability, IDD. Over half of individuals in services also have co-occurring mental health conditions, which may require additional support. BSS can supplement outpatient mental health services, but is not intended to replace them. Collaboration between BSS providers and mental health professionals ensures consistent strategies and coordinated care across all settings. General overview, service limits, and timelines. Behavioral support services, BSS, include 3 direct service elements, which are consultation, functional behavioral assessment, and comprehensive behavioral supports, and 1 indirect service element, clinical supervision. Key points include service limits. Consultation is up to 3 hours per month. Functional behavioral assessment, FBA, is up to 10 hours per month for a maximum of 2 months. Comprehensive behavioral supports are up to 12 hours per month. And clinical supervision is up to 1 hour per month, required for restrictive interventions. Timelines. Service start. Services begin on the start date indicated in the Service Authorization/Notice of Action, SANOA. Next, document completion. Consultation plan, FBA, and Behavior Support Plan, BSP, must be completed and uploaded to the BDS portal within 60 days of the service start date. Quarterly reports. They are required for consultation and comprehensive BSS, due by the 15th of the month following the quarter's end. 75-25 rule. At least 75% of billed services must be provided in person or through direct consultation with the individual and their team. No more than 25% of services should involve paperwork, research, or consultation with a clinical supervisor. The goal is to provide effective, time-limited support that fades as the individual achieves stability and independence. The minimum standard: the following document: consultation plan, functional assessment, behavioral support plan, competency-based staff training documentation, Human Rights Committee approval. Quarterly reports consultation is a streamlined component of behavioral support services, BSS, designed for individuals who do not require a formal behavior support plan, BSP, or comprehensive interventions. It focuses on maintaining stability and providing periodic guidance and training to the individual and their support team. Key features of consultation. Its purpose is to provide behavioral coaching, training, and consultation to reduce interfering behaviors and increase positive behaviors across environments. These are appropriate for individuals who have sustained success with current supports, do not need a formal BSP, require periodic consultation and training, and has service limits, up to 3 hours per month, 36 hours annually. Documentation requirements. Completion of a consultation plan, using the state-approved template, and quarterly reports to track progress and outcomes. There is no clinical supervision required, unless the individual or team requests additional guidance for complex cases. Here are the reimbursable activities: behavioral coaching and training for the individual and their support team, development of a consultation plan, quarterly reporting on progress and outcomes. This service is ideal for individuals who need minimal support to maintain behavioral stability and achieve their goals. Functional Behavioral Assessment, FBA, is a detailed evaluation process used to understand the reasons behind an individual's interfering behaviors and to identify strategies for positive behavioral change. It serves as the foundation for developing a behavior support plan, BSP, if needed. Key features of FBA. Its purpose is to assess the function and root causes of interfering behaviors using a biopsychosocial approach. It is appropriate for individuals who are new to behavioral support services, BSS, have significant behavioral needs outlined in their person-centered individualized support plan, PCISP, are experiencing significant behavioral regression or transitions, have an outdated or non-compliant FBA, and has service limits, up to 10 hours per month for a maximum of 2 months. This is the documentation requirement. Completion of an FBA report using the state-approved template, which must be uploaded to the BDS portal within the authorized time frame. Reimbursable activities are the following: observation, environmental assessment, record review, interviews, and data collection. Completion of the FBA report, including a historical account of the individual's development, trauma, and placement history. Behavioral coaching and consultation with the individual and their support team. The FBA provides a comprehensive understanding of the individual's behaviors and informs the development of effective strategies to support their progress toward a meaningful and self-directed life. Clinical supervision is an indirect service within behavioral support services, BSS, that provides oversight, guidance, and approval for direct service components. It is required when restrictive interventions are included in a behavior support plan, BSP, and can also be chosen to enhance support for complex cases. Key features of clinical supervision include the following. Its purpose is to ensure the quality, ethical standards, and effectiveness of behavioral interventions provided by behavioral consultants, BCs. It is appropriate for individuals who have a BSP with restrictive interventions, mandatory, require additional clinical guidance for complex behavioral or mental health needs, has service limits, up to 1 hour per month, 12 hours annually. Documentation requirements are the following: approval of FBA, BSP, and other relevant reports. Core principles of high-quality clinical supervision. First, direct working relationship. Regular communication and collaboration between the clinical supervisor and BC. Next, bidirectional communication. Open feedback and discussion to improve behavioral strategies and interventions. Next, access to records. Supervisors must have access to all relevant individual records to provide informed guidance. Another principle: coaching and mentoring. Supervisors help BCs develop clinical skills, navigate ethical boundaries, and improve service quality. Reimbursable activities are the following: review and approval of FBA, BSP, and other documents. Providing clinical guidance to ensure interventions are evidence-based, least restrictive, and feasible for implementation. Coaching BCs on clinical skills and approaches. Clinical supervision is essential for maintaining high standards in BSS, ensuring that interventions are person-centered, ethical, and effective in supporting individuals toward their goals. Services that are not allowed are the following: billing for multiple individuals at the same time, more than one direct service, disrupting other services delivered solely for convenience. ABA is not available as a waiver service. BSS is not directly billable or deliverable within school settings. While individuals may exhibit behavioral challenges at school, addressing these behaviors is the responsibility of the school team using Department of Education, DOE, funding and resources. Key guidelines for BSS in schools. Service delivery limitations. BSS cannot be provided as part of the school day or directly within the educational environment. BCs cannot engage in one-on-one interventions during school hours. Collaboration and information sharing. With guardian consent, BCs may share the Behavior Support Plan, BSP, with school personnel to promote consistency across environments. BCs may attend Individualized Education Program, IEP meetings, or conduct limited observations in the school setting to gather information for the BSP. Intent and purpose. Any involvement in the school setting must focus on improving behavioral outcomes in non-school environments, such as home, community, workplace. BSS is not intended to fix behaviors or manage individuals, but to empower them to learn new behaviors and improve their quality of life. Key considerations: BSS is not a substitute for traditional applied behavior analysis, ABA, or DOE-funded services. BCs should avoid activities that primarily benefit the individual in the school environment and focus on strategies that support success in other settings. Competency-based training in BSS. Competency-based training ensures that staff, especially home and community support professionals, HCSPs, are equipped to provide safe, effective, and person-centered support. It is the responsibility of the Behavioral Support Services, BSS provider, to ensure staff competency, both at the time of hire and through ongoing training. Key elements of competency-based training. Initial and ongoing training. Staff must complete initial training and demonstrate ongoing competency in areas relevant to the services they provide. Training must align with person-centered principles, emphasizing dignity, choice, and community inclusion. Documentation. BSS providers must maintain records of all training and competency verification. Training methods. First, train the trainer model, which is used for general needs. Next, direct training by BC. For individuals with high behavioral needs or complex interventions, BCs may train staff directly. Next, hands-on instruction. Training should occur during regular support schedules, with BCs providing hands-on instruction and observation to ensure staff confidence and competence. Lastly, collaborative approach. BCs should work with the individual and their support team to determine the most person-centered training approach. Here are the key goals. Protect individuals from harm. Empower individuals with a sense of safety. Strengthening overall quality outcomes. Ensure strategies are implemented consistently across all settings by both paid and natural supports. Behavioral Support Services, BSS, are now authorized on a quarterly basis instead of annually. For example, if an individual is approved for 6 hours, 24 units, of comprehensive behavioral supports per month, they will be allowed to use up to 18 hours, 72 units, within each 3-month period. This change means that service hours cannot be spread across the entire year, but must be used within the specific quarterly authorization period. For instance, if the annual Service Authorization Notice of Action, say NOAA, starts on March 1, 2026, The first quarter would cover March 1st to May 31st, 2026. To ensure proper documentation for services rendered under Behavioral Support Services, BSS, the following details must be included. First, individual information, name and recipient identification number, RID, or Indiana Health Coverage Programs, IHCP, member ID. Service details, type of service provided, date, start and end times, with AM/PM designation, and primary location. Provider information, name of the behavioral consultant, BC, delivering the service. Summary of activities, description of tasks performed, outcomes achieved, and any issues or incidents related to the individual. Multiple encounters, separate notes for each encounter in a day. Specificity, clearly indicate the location, allowable activities completed, and context of the service provided. Supporting documentation, include references to research, training, or documents developed during the service. Accurate and detailed documentation is essential for compliance, billing, and ensuring quality service delivery. The BDS portal. It is your responsibility as a BC to ensure that all required documents are uploaded into the individual's record. This makes access easy for all providers on the IST. Further, this is how case managers, BDS, and auditors assure compliance and assess quality metrics. The Positive Behavior Supports, PBS framework is an evidence-based approach that focuses on improving quality of life by teaching new skills and reducing challenging behaviors. Key principles include behavior as communication. It recognizes that challenging behaviors are expressions of unmet needs or communication. Proactive strategies. Emphasizes preventing challenging behaviors by addressing triggers, structuring environments, and teaching alternative behaviors. Person-centered approach, which focuses on the individual's strengths, interests, and goals to create meaningful and respectful interventions. Skill building. It encourages teaching replacement behaviors that meet the same needs as the challenging behaviors in a more appropriate way. Collaboration. It involves the individual and their support team across all settings to ensure consistency and effectiveness. Focus on quality of life. It aims to empower individuals to live meaningful, self-determined lives with dignity and respect. PBS integrates principles of applied behavior analysis, ABA, with humanistic values, emphasizing positive reinforcement, proactive planning, and understanding the individual's lived experience. It is aligned with CMS values and required in Indiana's Home and Community-Based Services, HCBS, waiver program. Independence versus interdependence highlights two approaches to supporting individuals with intellectual and developmental disabilities, IDD. Independence focuses on self-sufficiency, autonomy, and the ability to act without relying on others. It emphasizes mastering daily living skills, managing personal decisions, and functioning independently. While valuable, an overemphasis on independence can overlook the reality that everyone relies on others to some degree. Interdependence, on the other hand, recognizes the importance of mutual support and connectedness. It values collaboration, reciprocal relationships, and natural supports, emphasizing that true empowerment comes from being part of a system of relationships where individuals both give and receive support. Interdependence aligns with person-centered principles, promoting community inclusion and shared decision-making. The goal is to help individuals with IDD live meaningful, self-determined lives, balancing independence with interdependence to foster autonomy while respecting the need for support and connection. Identifying interfering behaviors involves understanding behaviors that hinder an individual's ability to achieve their goals and live a meaningful life. Key considerations include behavior as communication. Recognize that behaviors often serve as a form of communication or expression of unmet needs. Objective assessment. Determine if the behavior truly interferes with the individual's success in accessing their community and achieving their goals. Avoiding subjectivity. Focus on behaviors that are obstacles to the individual's good life, rather than labeling behaviors based on personal preferences or societal norms. Here are the behavior categories. Behaviors requiring structured interventions. Examples include physical aggression, self-harm, stealing, or behaviors that pose safety risks. Behaviors not requiring formal interventions. Examples include burping, passing gas, or refusing to go to bed at a set time, which may be addressed through informal training or accepted as part of the individual's personality. The process emphasizes understanding the individual's perspective, removing bias, and focusing on behaviors that genuinely impact their ability to thrive. Replacement behaviors. Replacement behaviors are positive alternatives to interfering behaviors that meet the same need or function. They should be functional equivalent, which address the same underlying need as the interfering behavior. Efficient and achievable, easier and more effective for the individual to perform. Teachable, can be learned and practiced across settings. Acceptable, appropriate for the environment where the interfering behavior occurs. Proactive versus reactive strategies. Proactive strategies focus on preventing challenging behaviors by addressing underlying needs, teaching new skills, and structuring the environment to promote success. Examples include visual schedules, offering choices, and teaching self-regulation. Reactive strategies. They are used after a challenging behavior occurs to ensure safety and de-escalate the situation. Examples include planned ignoring, calm redirection, and de-escalation plans. Reactive strategies should be temporary and inform adjustments to proactive plans. Addressing symptoms associated with mental health conditions. Behavioral support plans, BSPs, can help manage mental health symptoms by providing consistent strategies to help individuals feel safe and secure during episodes. Facilitating data collection to monitor the impact of psychotropic medications and inform adjustments to strategies. Non-compliance. The term non-compliance is discouraged as it is not person-centered. Individuals have the right to make choices, even if they differ from staff expectations. Instead, use terms like chooses not to participate or deferred choice to respect autonomy. Formal interventions should only address non-compliance if it poses a health or safety risk. The word inappropriate. The term inappropriate is subjective and not person-centered. It can demean individuals and create confusion. Instead, use clear, objective descriptions of behaviors. For example, threatening others, instead of inappropriate language. This approach promotes respect and understanding while avoiding judgmental language. Restrictive interventions versus aversive techniques. Restrictive interventions are methods that limit an individual's freedom of movement or access to ensure safety. These are allowed but must be justified, time-limited, and regularly reviewed for reduction or elimination. Examples include locking doors or using PRN psychotropic medications. Aversive techniques are punitive methods intended to cause pain or discomfort to suppress behavior. These are unethical and strictly prohibited in Indiana's HCBS waiver programs. Examples include seclusion, physical punishment, or denial of health-related necessities, including interventions in a BSP. Restrictive interventions can only be included in a behavior support plan, BSP, if there is a documented assessed need tied to health and safety risks. Less restrictive methods have been tried and failed. The intervention is the least restrictive option and is time-limited. Informed consent is obtained from the individual and their legal representative. Approval is granted by the Human Rights Committee, HRC, and clinical supervisor. When can rights modifications be considered? Rights modifications can be considered only when there is a documented health or safety risk. Less restrictive interventions have been tried and failed. The modification is a last resort and time-limited. Informed consent is obtained, and the modification is approved by the HRC, and a plan to fade or eliminate the modification is outlined and regularly reviewed. Psychotropic medications. Psychotropic medications should treat diagnosed mental health conditions, not solely control behavior. Routine medications prescribed for mental health diagnoses are not considered restrictive, but PRN medications, or those prescribed specifically for behavior control, are restrictive. BCs should collaborate with prescribers, attend appointments, and monitor medication effects. But prescribing decisions remain the responsibility of licensed medical professionals. Reinforcement. First, positive reinforcement. It encourages desired behaviors by providing meaningful rewards. It should be individualized, dignified, and embedded in natural environments. Next, reinforcement schedules. Structured systems can be used to encourage behavior change, but they must avoid punitive measures and focus on teaching new skills. Reinforcement should prioritize giving to what is good rather than taking away privileges. Alternatives to discuss with prescribers. Behavioral consultants, BCs, can collaborate with prescribers to ensure psychotropic medications are used appropriately and effectively. The focus should be on treating diagnosed mental health conditions rather than solely controlling behaviors. BCs can suggest alternatives or adjustments to medication plans, but prescribing decisions remain the responsibility of licensed medical professionals. Key points for discussion with prescribers. Shift focus to diagnoses. Medications should be prescribed to treat specific mental health diagnoses rather than targeting behaviors. For example, instead of Risperdal 2 mg BD for aggression, suggest Risperdal 2 mg BD for schizophrenia. Instead of hydroxyzine 25 mg TID for constant pacing, suggest hydroxyzine 25 mg TID for generalized anxiety disorder. Monitor side effects. BCs can help identify and report side effects that may impact the individual's quality of life, such as excessive sedation, weight gain, or tremors. Collaborative approach. BCs should provide prescribers with relevant behavioral data, such as frequency, intensity, and duration of behaviors, to inform medication decisions. Presenting concise summaries or graphs is more effective than lengthy reports. Avoid over-medication. BCs should advocate for the lowest effective dose and avoid over-reliance on medications. They should also ensure PRN medications are used only as prescribed and not for convenience or compliance. Ethical considerations. BCs should avoid pressuring prescribers to make medication changes for convenience or to avoid incident reports. Instead, they should focus on person-centered approaches and evidence-based practices. Role of BCs in medication management. While BCs do not prescribe medications, they play a critical role in monitoring their impact, collaborating with prescribers, and ensuring that medication aligns with the individual's behavioral goals and overall well-being. This collaboration helps ensure that psychotropic medications are used ethically and effectively. Reinforcement. Positive reinforcement strengthens desired behaviors by providing meaningful rewards that are individualized, dignified, and naturally embedded in daily life. It focuses on encouragement and success rather than control or compliance. Reinforcement schedules. Structured systems can help individuals achieve behavior change but should avoid punitive measures. They should prioritize giving to what is good rather than taking away privileges. Risk versus benefits. Analysis. This analysis ensures that behavioral strategies promote growth, independence, and safety while minimizing risks. It involves input and consent from the individual and their team, ensuring interventions are least restrictive and person-centered, balancing the dignity of risk with safety and autonomy, regular reviews to assess the effectiveness and necessity of interventions. Human Rights Committee, HRC. The HRC ensures that restrictive interventions in a BSP are necessary, ethical, and time-limited. Their role includes reviewing restrictive interventions to ensure they are the least restrictive option, promoting person-centered approaches, and safeguarding individual rights, approving restrictive interventions only when informed consent is obtained and a plan for reduction is outlined. Requirements. Here are the requirements. First, at least 3 members, including a non-authoring BC, a professional with relevant expertise, and an individual with IDD. Next, regular reviews of restrictive interventions, at least annually. HCBS settings rule. It ensures individuals receiving Medicaid-funded services have the same rights and opportunities as those without disabilities. It emphasizes choice, dignity, privacy, and inclusion. Independence and interdependence over dependence on paid supports. Key rights include privacy, choice of supports, community access, and freedom to live and work as valued members of society. Trauma-informed approaches. These recognize the high prevalence of abuse, neglect, and exploitation among individuals with IDD. Trauma-informed care emphasizes safety, trustworthiness, choice, collaboration, and empowerment, avoiding re-traumatization and fostering emotional and psychological safety. For example, Suzanne, who experienced trauma as a child, becomes agitated when her bedroom lights are turned off. Instead of forcing compliance, her team uses trauma-informed strategies, such as allowing her to keep the lights on, offering a nightlight, and practicing grounding exercises to help her feel safe. Biopsychosocial approach. This approach considers biological, psychological, and social factors to understand behavior and recommend interventions. For example, Ashia, diagnosed with schizoaffective disorder, exhibited interfering behaviors linked to poor sleep. A sleep study revealed she had narcolepsy, which was treated with appropriate medical interventions. This led to behavioral improvements, reduced medication, and successful employment. Ethical issues for BCs. BCs must adhere to ethical standards, avoid conflicts of interest, and maintain professional boundaries. Ethical issues include dual relationships. BCs should avoid serving individuals if they have personal relationships, for example, family member, teacher, or counselor, that could impair objectivity. Role integrity. BCs should focus solely on behavioral outcomes and avoid taking on roles outside their scope, such as case manager or nurse. Responsibility to the individual, holding the system accountable. BCs must ensure the system supports the individual's health, safety, and rights. This includes reporting abuse, neglect, or exploitation, ANE, through incident reports, IRS, filing complaints with the statewide waiver ombudsman for service quality concerns, and advocating for the individual's needs and holding team members accountable. BC accountability. BCs must uphold ethical standards, follow policies, and ensure compliance with state and federal regulations. Violations can lead to serious consequences. Examples of unethical behaviors in HCBS waiver program settings: falsifying documentation or billing fraud, failure to report ANE or critical incidents, violations of individual rights or person-centered planning principles, inadequate qualifications or background checks, retaliation against whistleblowers, violations of the HCBS settings rule, conflicts of interest or dual relationships, consequences for violations, corrective action plan, CAP, monitoring and required improvements, moratorium, halting new referrals to the BC or agency, paybacks, repayment of fraudulent billing claims to Medicaid, revocation, termination of the provider agreement with BDS, and criminal charge, prosecution for severe violations, such as fraud or abuse. Behavioral support services exist to protect rights, support meaningful lives, and ensure people receive care that is ethical, person-centered, and least restrictive. When we use respectful language, collect accurate data, collaborate with the IST, and prioritize dignity and safety, we do more than meet compliance. We build trust and quality of life.